Question number 127, malabsorption. Now, the individual disease processes that are going to be covered in the question have relatively lesser amounts of morphological changes that you are probably used to from other pathologies that we've discussed in previous questions and in previous chapters. So, yeah, good stuff for you. But having said that, the question stem itself has a lot of diseases that are very heavy on their pathophysiology, so it's important that you understand these. They're not too difficult, and usually the diseases that we are going to discuss normally have common symptoms across the board. Of course, they will also have some specific symptoms which I will elucidate. So, in malabsorption syndromes, the basic idea is that nutrients are no longer being absorbed across the small intestines. So, nutrients are no longer effectively absorbed in the small intestines, and these can be broadly divided into digestive disorders, so you're having issues in breaking down specific nutrients, or they can be absorption defects, meaning that you are lacking the required maybe enzyme, or in just general you have too much damage done to the small intestines that are preventing you from having absorption. Now, another classification, another way, I mean, it's not really a classification as such, but it's more the effect that these malabsorption syndromes do have, and that's simply you can have malabsorption of macronutrients, so this being your proteins, your carbohydrates, your fats, or you can have malabsorption of micronutrients, so this being stuff like your vitamins and your minerals. Malabsorption can also be global, meaning that all nutrients are affected, or it can be partial, meaning specific nutrients are affected. And now the overall problem, or the overarching theme, is when you have malabsorption syndromes, you have nutrients that remain in the GI lumen for too long, and this can interfere with stool formation, these nutrients can be lost within the stool, and if you're not absorbing nutrients, you can have unintentional weight loss. Now then, moving on to macronutrient malabsorption, and just an idea for the presentation that a patient will have if they do have malabsorption of macronutrients. And the first one we're going to talk about is fat malabsorption. And so if you have fat malabsorption, your patient will present with steatorrhea, which basically means that their stools are going to be fatty, greasy, voluminous, and they are going to smell really bad. So plus terrible smell. Now the real issue with fat malabsorption is that you are decreasing the absorption of fat dependent, or fat soluble rather, vitamins. So this means vitamin A, D, E, and K. And so a patient can present with symptoms that make you into deficiencies of these vitamins. Just to list a few for you, a patient with vitamin A deficiency can present with night blindness, They can have corneal ulcerations, and they can have eye dryness as well. These are relatively not important. You don't really have to mention them unless really asked, but it's good to know that if you're going to talk about vitamin A, D, E, and K not being absorbed properly across the bloodstream, what could the patient presentation look like? Because like I said earlier, this question really does not have a lot of morphology as such. So these are some of the brownie points, the things that you can talk about to score some, to just get your exam going more than anything. Then vitamin vitamin D rather, not being absorbed. Go in order. This normally has presentations in children with rickets. More on that in locomotor pathology, and in adults with the presentation is normally osteomalacia. And then I will fit in vitamin E as well. Patients normally have impaired proprioception and vibratory sensations. They may present with hemolytic anemia as well, so this is one of the causes of hemolytic anemia. And they could also have ataxia. Vitamin K, I've unfortunately run out of space here, but you can imagine vitamin K, if it's not happening, your coagulation cascade is going to have a bit of an issue functioning, right? So that's it as far as fat malabsorption goes. Then moving on to malabsorption of carbohydrates and proteins. So carbs plus proteins. The issue is, so if you can imagine here, we've got the lumen of the small intestine. If these carbs and proteins are not absorbed across the intestines, they can attract water into the lumen because they are osmotically active particles, which results in watery diarrhea as compared to steatorrhea when you have fat malabsorption. So watery diarrhea. And with protein malabsorption, you can also have presentation of edema because you have a lowered oncotic pressure. Basic physiology, nothing too deep into it. So now let's discuss the first division of malabsorption syndromes, which are digestive disorders. This basically means that within the lumen itself of the small intestine, the food that you would end up eating cannot be broken down into smaller pieces and smaller soluble compounds that can be absorbed across the small intestines. And so the first digestive disorder we're going to talk about is exocrine pancreatic insufficiency. So exocrine pancreatic insufficiency. And so what's basically happening in this is that you have a lack of pancreatic digestive enzymes being produced. So these are your pancreatic amylase, lipase, elastase, and this will then, because these enzymes are not present and they cannot carry out their functions, the patient will normally present with symptoms of global malabsorption, most of which we already discussed up top. So the etiology, what causes pancreatic insufficiency? There's a whole question on pancreatitis later on, which will go into further depths of what causes pancreatitis as is. But for now, all you need to know is that pancreatic insufficiency can be caused by chronic pancreatitis, in which the inflammatory process leads to destruction of the exocrine portion. of the pancreas. So exocrine portion damaged. In adults, this is mostly due to alcohol abuse, which causes viscous and thick pancreatic juices to be produced, which end up blocking the exocrine ducts, and then you have the further pathophysiology of it. I'm not going to go into it in this question specifically, but if you do talk about chronic pancreatitis as part of your question in this, you're very likely going to be asked about how the pancreas looks on gross morphology. So yeah, that's something you can throw in as far as morphology goes for this question. And then in children, the most common cause of chronic pancreatitis is cystic fibrosis. Again, a whole question on this in general pathology and later on in pancreatic pathology as well. Not going to go too deep into it, just know that these are the causes. Right, then the second digestive disorder that we need to talk about is cholestasis, which you probably already know is, in very simple terms, just impaired bile flow. And normally when you have cholestasis, you will obviously have morphological changes depending on at what level the cholestasis is occurring. If you have hepatocellular cholestasis, the gross morphology of the liver changes. You should know that. If you have obstructive cholestasis, again, a specific morphology you need to know for it. I'm not going to go into too much detail of those morphological changes in this question solely and only because these questions are covered in much more detail later on. So when we get to them, those morphological changes will be covered. You can talk about them though in this question as well. But just to keep things a little simple and give you some pointers on liver histology, you can be asked this. In the case of cholestasis, you will have yellow green bile lakes present. And so if you have cholestasis, the nutrient that is most affected by this form of digestive disorder is your fat absorption. So you're going to have fat malabsorption and its presenting symptoms, which we already discussed early on. And this is because, as you know, bile is needed for the emulsification, which is to increase the surface area of fats for their absorption. And so effectively, if bile is not getting into the intestines, this process is completely blocked and you cannot absorb fat. So what are some of the causes of cholestasis? Can be divided into hepatocellular cholestasis, it can also include obstructive cholestasis, or it can simply be due to carcinoma on the head of the pancreas. And of course, if you have carcinoma on the head of the pancreas, what this does is that it causes a further obstruction, an external obstruction rather, in the biliary tree and the biliary outflow, preventing bile from getting to the small intestines. So hepatocellular cholestasis, what are the causes? By definition, first simply, it's that your hepatocytes are not producing enough bile. And one of the more common causes, of the common etiology associated with this, is high levels of estrogen in the body, which inhibits bile acid secretion by blocking the pumps that are the export pumps that pump bile out into the biliary tract or the intrahepatic biliary tract. And when you have a buildup of bile, so buildup of bile acid, this will result in further down regulation of bile synthesis. And I might as well just mention it, just a little bit about it, so you're not completely lost. As far as morphology goes, with the liver specifically, already mentioned that you will have yellow-green bile lakes on liver histology, but the liver itself will appear larger, and it has a yellowish to green discoloration on gross inspection. Discolor. Cool. Then coming to obstructive cholestasis, by definition this is just physical blockage of bile flow. And this is commonly seen in cases of primary sclerosing cholangitis. Just a little bit about the morphology. What basically happens in this is that you can imagine this being your bile duct, and what's going to happen is that the cells that line up the bile duct undergo inflammation. They die out, they're affected by inflammation rather, they die out, and they are hardened by fibrosis. This can occur both in the intrahepatic bile ducts and the extrahepatic bile ducts, and because of this fibrosis, what ends up happening is that you have tightening of ducts in the area of serious fibrosis and relative dilation in the less affected areas, and this ends up giving a presentation of multifocal strictures within the biliary tree that is affected, and it gives it a, on gross morphology, a beads on string appearance. Again, these are specific pathologies on their own, more on their morphology, their histology, whatever, in other questions, but this is, I did say I'm not going to mention them, but just to make sure you're not completely lost in case you are asked this specific for this question, these are some of the things you can mention. And then the third and last digestive disorder we're going to discuss, a relatively common one which you should know, is lactose intolerance. And this is a disease process that is characterized by decreased activity of the lactase enzyme that is present in the intestines. And what lactase does is that it converts dietary lactose into its monomer sugars, those being your glucose and galactose. This can be congenital, however this is relatively very rare, and the acquired form of lactose intolerance is more common, in which cases you have damage to the lactase enzyme occurring secondary to infection or just gene down regulation. On histology, you will normally see that the intestinal mucosa is normal. And so a bit about the pathophysiology, what is actually going on in this case. When you have lactose building up in the intestinal lumen, not being broken down, what happens is the lactose is then fermented by bacteria in the gut. And so with this you can have production of, in this fermentation process you can have production of short chain fatty acids that attract H2O into the lumen, and you can have release of gases as well. And so this is why a patient who is lactose intolerant, once they have a lactose rich food item or just milk drink item too, they present with gas and bloating because of the H2O being attracted into the lumen. Because of the short chain fatty acids, they present with diarrhea and abdominal pain. After the injection of milk and the dairy products. And so that is it as far as digestive disorders go. Now we're gonna get to the second type of cause, the second branch of malabsorption syndromes, which is absorption defects. And so what's basically happening in absorption defects is that there are disease processes that damage small intestinal mucosa, resulting in an overall decreased surface area for absorption. And so you will normally see a patient present with symptoms of global malabsorption. And so the first disease we're going to talk about is celiac disease. This is an immune mediated damage to the small bowel that occurs secondary to gluten exposure. And so this does have a few morphological changes and histological changes that we will talk about, but first a bit about the pathophysiology of what's happening in celiac disease. So it begins with the ingestion of gluten. And what basically happens is when gluten is taken in, it is broken down into gliadin. Now gliadin is going to, I'm going to represent gliadin as this small little circle over here. What's going to happen is that this gliadin is going to bind to IgA antibodies that are present on the mucosal membrane of duodenal cells. So IgA antibodies present in the duodenal cells, the mucosal membrane of the duodenal cells. And so from here, what happens? Normally, this complex now that is formed, I'll draw it out here actually, in normal circumstances, this is completely phagocytosed. So this complex is phagocytosed. However, in the case of celiac disease, what happens? So celiac disease, we look at the mucosa, right? And we've got this little IgA antibody and the gliadin complex sitting here. What's going to happen is that this complex is going to interact with transferrin receptors. So transferrin receptors that are found on the surface membrane of these of the mucosal cells of the duodenum, right? And what this is going to do is that this will transcytose, so endocytosis. The entire IgA gliadin complex into the lamina propria. Once this happens, you have deamination of the gliadin complex by tissue transglutaminase, and this produces deaminated gliadin. And now this is where your autoimmune involvement comes in patients who are genetically predisposed, having the HLA DQ2 or HLA DQ8 phenotype. This deaminated gliadin is rather phagocytosed by macrophages, and through MHC class 2 presentation you have antibodies that are produced against this. You don't really need to go too deep into how the antibodies are produced. Just plasma cells, CD4 T cells being activated, then B cells being activated, and then producing IgA antibodies. And now it's important to understand what these IgA antibodies target. And so they target gliadin, they target tissue transglutamase, which was the enzyme we discussed that deaminates gliadin, and it also targets endomysium proteins. So endomysium proteins, and with all of this, with these, when these IgA antibodies target these specific these specific proteins and molecules that we've discussed, this further stimulates helper T cells to release cytokines and initiate an inflammatory response, and this results in a direct attack to the villi. And so this is where morphology comes in. If you take a duodenal biopsy, and why a duodenal biopsy? It's simply because the transferrin receptors that usually transcytose the gliadin IgA the complex rather, are found within the duodenal cells. So in a duodenal biopsy, what are you going to see? First thing you're going to see is that you will have a flattening or blunting of the villi in the small bowel, and this is obviously going to be more prominent within the duodenum. And in severe cases you may also see ulcerations. As far as histological findings go in the biopsy, that can present with villus atrophy, crypt hyperplasia, which basically means you are going to have deeper crypts, and you're going to have a decreased height of the enterocytes. You can also have intraepithelial lymphocytosis, and lastly you can have decrease or a loss in the brush border making up the intestines. So these are some of the morphological changes that you will see at the macroscopic and the microscopic level of the intestine, one in the case of celiac disease. Now a few complications worth knowing, which are relatively very important, of celiac disease. The first one is that patients who have celiac disease have an increased risk of developing a type of lymphoma that is known as enteropathy, so E, associated T cell lymphoma, also known as ETL actually. And this is a rare form of non-Hodgkin's lymphoma, whole lecture on that, and this affects the small intestine and it is closely linked with celiac disease. It typically does occur in adults who have a long-standing history of untreated celiac disease. Another thing that can happen is that you can have a condition known as dermatitis herpetiform, which is basically a skin condition that is characterized by chronic itchy and a blistering rash. And the rash itself, if you're asked to describe its morphology, it normally presents with small vesicles You learn further in skin pathology what a vesicle is, but it is basically when you have an elevation that is less than 0.5, I believe it was centimeters, so less than 5 millimeters in height, and this vesicle is filled with clear fluid. And so this process occurs because these IgA antibodies that are produced, which we spoke about, can target certain proteins, specifically transglutaminase enzymes that are found within the skin as well. And so that is pretty much it for celiac disease. The other 3 diseases we have to cover are relatively shorter, not a lot much to it, so let's go through them really quickly. So the second disease that causes absorption defect is known as tropical sprue. This is basically a result of bacterial overgrowth, and the bacteria that are normally involved include Klebsiella, E. coli, Enterobacter. And you can imagine if you have higher amounts of bacteria present within the lumen, they can ferment the food that is found within the intestine, the food you eat, and this can result in toxins that trigger a chronic inflammatory response. So if you have chronic inflammation, you can have damage to the small intestines, and this normally morphologically presents with flattening of the small intestine villi, as you did see in celiac disease. But this more commonly affects, as compared to celiac disease, the ileum and the jejunum. And as far as patient manifestation and presentation goes, they will present with symptoms of global malabsorption. That's it for topical sprue. The third one that we're going to talk about is Whipple's disease. This is basically a systemic infectious disease rather, with the species Trophirema, I hope I'm pronouncing that right, Trophirema whippeli, which is a gram-positive actinomyces, and it is normally transmitted fecal-orally. What basically happens as far as pathophysiology is concerned, you probably remember from histology or just basic high school biology, that the intestines within the cells, within their absorptive cells, have something that is known as a lacteal, which is normally responsible for the absorption of fats, right? Fats and fat dependent vitamins that are absorbed. So what basically happens is, within these lacteals you also have macrophages present, and what macrophages do is that they digest the causative agent we just discussed, which is Trophirema whippeli, but they are unable to break it down, and this organism remains within lysozymes. And what this then results in, normally seen on histology but morphological changes, is that you can have an enlarged foamy macrophage infiltration of the lacteals, and this macrophage infiltrate can also extend to the lamina propria. Anyway, the other important morphological change that you will see is Willis expansion, and on gross inspection of the intestine you will see yellow mucosal plaques due to lipid deposits. Once again, just to drive home the point of the histological change we see, we'll see that these, you have an accumulation rather of foamy macrophages. You remember foamy macrophages from atherosclerosis, so something like that in the lamina propria, and that these macrophages stain or are rather pass positive. And so one last disease to discuss really quickly is A beta lipoproteinemia. This is an autosomal recessive disease that is characterized by apolipoprotein B48 and B100 deficiency. And in this case, these patients basically have malabsorption due to defective chylomicron formation. And yeah, that's pretty much it for absorption defects and as a whole of malabsorption syndromes. Just remember that because there are individual diseases such as the ones we discussed with respect to hepatocellular cholestasis or cancers of the pancreatic head, you may be asked to talk about the morphology of these specific diseases. If necessary, do mention them. They are covered in more detail in the questions, but I did give a bit of an overview of what the morphology would look like, just so you're not completely lost in case you haven't reached that part yet. And that should pretty much be it for this question.